mucinous variant if there is a lot in the initial biopsy and then take it up for a resection, like a full thickness resection? Because none of the guidelines actually do state any of that.
Yeah, because any signet cell type lesions, which I have shown the first case, diffuse variety of the cases, although the surface lesion will be very small, EUS will definitely pick up the diffuse edema, submucosal edema and thickness of the area beyond 2.5 centimeters. Most of the other incidental lesions do not fall into that category because the stomach looks absolutely normal other than the EGC. So those are the cases which should be taken up for the resection.
So, okay. So resection versus surgery. Would you still go ahead with an endoscopic approach then?
Not for the signet cell or diffuse or poorly differentiated ones.
Okay, thank you. So I think the floor is open for any questions.
Again, a question to endoscopist. Would like to know how many of your patients had lymphovascular invasion and what exactly the kind of tumor it is, and I would like to know some more details, because would you also wait for a biopsy report to come, and then in case if there's any lymphovascular invasion you would like to hand over to the surgeon, or what exactly?
Yeah, that is, most of the well-selected groups do not have lymphovascular involvement and positive margins. Deeper margins are taken care. And the study which my previous speakers quoted, long-term follow-up, there is no overall survival difference in patients who had positive margin, is because the diathermy would have cleaned up the cells which would have been picked up on the histology. So post-diathermy, death of those surface cells will not show up on the histology, but follow-up, 3 months follow-up imaging would be the ideal one to restage them and offer any treatment. It is not very common to have lymphovascular invasion in EGC cases as opposed to colorectal type of cases if they are confined to SM1 or SM2.
I just wanted to know from your experience in your cases, so how many of them had or did not have, none of them did not have lymphovascular invasion?
All my cases, no case was ever found to have any lymphovascular invasion if my margins were clear.
Suppose the BABS comes as in, it has any lymphovascular invasion, so what do you suggest?
We would suggest surgery.
Good morning, I am Dr. Ramesh Parami, surgical oncologist. Well, after the submucosal resection for early gastric cancer, which is not so common, would you suggest any kind of change in the staple diet? If you go through the previous records of 50 years back, the NIN, National Institute of Nutrition, Hyderabad, had published a paper wherein change in the staple diet once in every 2 decades or 15 to 20 years would statistically reduce the incidence of stomach cancers. This paper was published long ago. Later on, I too lost track of it. Would you like to suggest any change in the staple diet following your ESD?
Normal traditional advice would be stopping smoking and tobacco chewing and corrosive things. Even tea, coffee are also linked in the older papers to this one, but I am not aware of change of diet, because if you look at the retrospective thing, it would have already had the effect on the gastric mucosa leading to intestinal metaplasia or atrophic gastritis. So H. pylori has much more role in than the dietary role, because that is the single most implicated thing. Fortunately, not in India. There is topographical variation. The communities where H. pylori recently, until in last 400-500 years, if they developed, there the incidence of early gastric cancer related to H. pylori is very high compared to the Southeast Asians. So we do not fall into that group where we have highest incidence of H. pylori, but not that high incidence of gastric carcinoma.
I have one more quick question. Now, you had a positive margins on your endoscopic resection, and you were talking about reassessing after 3 months. Now, would you actually refer this patient for surgery, or would you think about chemotherapy in this interim period? Or we just wait for 3 months and reassess?
So if pre-endoscopic staging is T1, and the post-resection margins are positive, we would directly refer to the surgeons. Only if the lateral margins are positive on one edge, where we are confident that the area is treated by, sometimes we do the APC and diathermy effects. In those cases, selective cases, we can wait.
Okay. Thank you, sir.
Because deeper margin is more important. We pay more attention to the deeper margin. Deeper margin definitely has to go. So you restage them. Deeper margin, so the revised stage will be T2.
Are there any protocols to detect early recurrences or lymph nodal metastasis in these cases?
All the post-ESD patients should have 3-monthly endoscopy at least for 1 year. Then yearly.
To 1 year, post 1 year?
Post 1 year, yearly.
Yearly. So if you find any of these signs of metastasis or recurrence, so would you suggest directly go to surgery again after that?
Yeah,